Neuromuscular disorders, myasthenia gravis, multiple sclerosis, and muscle spasms. Myasthenia gravis is an autoimmune thymus gland issue. Acetylcholine secretion is low. Sites on the cell can also be impaired. The overall result is that the patients have weakened skeletal muscles. Myasthenia gravis medications include some first-line medications, which are acetylcholinesterase inhibitors or cholinesterase inhibitors. So if you remember, cholinesterase inhibitors inhibit that thing in between the neuron and the muscle that break down acetylcholine. So these medications actually make more acetylcholine reach the muscle. So you get better muscle use, better muscle contraction. Neostigmine or prostigmine is short-acting. Endrophonium or tensilon is ultra-short-acting for diagnostic purposes. Pyridostigmine or mestinon is intermediate-acting. Ambinonium or amylase is long-acting. There are a few problems with this. Sometimes myasthenia crisis can occur. That's when someone's underdosed. And sometimes cholinergic crisis can occur. That's when someone's overdosed. The goofy part about that is sometimes you can see the same symptoms, so one of these drugs needs to be used as a diagnostic tool. Myasthenic crisis, if the levels are too low. This happens 3 or 4 hours after administration because, long story, severe muscle weakness is the symptom. The respiratory system can actually be involved. It improves after tensilon and or neostigmine is given. Cholinergic crisis is overdosing. Half hour to 1 hour after administration of a med, severe weakness, possible respiratory paralysis and arrest, abnormal pupil constriction, salivation, sweating, excessive pallor, vertigo, GI distress, bradycardia, and fasciculations. If tensilon is given, it gets worse. And remember, tensilon is that short-acting guy. So if that's given and it gets worse, it wears off, and then you know how to go about treatment. Multiple sclerosis. Multiple sclerosis is an autoimmune disorder where the myelin sheath of the brain and spinal cord are attacked. There are exacerbations and remissions. The result, there's weakness, spastic extremities, diplopia, double vision. Acute attacks are treated with steroids and adrenocorticotropic hormone. There are periods of remission and exacerbations. And the disease is thought of as chronic and progressive. And when it is chronic and progressive, they do turn to immunosuppressant therapy. Skeletal muscle relaxants include the following: baclofen or lioresal, tizanidine or Zanaflex, carisoprodol or Soma, chlorzoxazone or Paraphone Forte DSC, methylcarbamol, or Robaxin, metaxalone, or Skeletal, or phenedrine, or citrate. Direct acting include dantrolene sodium, or dantrium. These are depolarizing muscle relaxants, which are anesthesia adjuncts. Pavilon, succinylcholine, or anectine, vecuronium, or norcuron, tubocurine. Flexeril. This is a really common med. What does it do? It relaxes skeletal muscles. It alleviates muscle spasm associated with acute painful musculoskeletal conditions. Side effects? The anticholinergic effects are prevalent with this. You get abdominal pain, vomiting, diarrhea, flatulence, fever, drowsiness, dizziness, headache, and erectile dysfunction.